Well, good evening, everyone. And it's really a special night tonight since we have Dr. Damon Tweedy who will be speaking to us. But before that, I'd like to introduce to you our First Lady, Dr. Archie, as we call her, Chatterjee. She's really been at Rosalind Franklin since April of 2020. She is our first woman dean that's here. She's also the vice president for medical affairs, and I welcome her to say a few words to many of you. Thank you, Dr. Chatterjee.
Thank you very much, Dr. Olivier. A very good evening to all of you. On behalf of the Chicago Medical School and Rosalind Franklin University, it is my distinct honor and pleasure to welcome you all this evening to the seminar entitled Reflections on Race and Medicine in the Year of COVID-19 and Nationwide Protests that is hosted by the CMS Office of Excellence in Diversity and Inclusion and will be presented by Dr. Damon Tweedy. We are delighted to have such a distinguished speaker to address this critical topic. COVID-19 has highlighted the disproportionate healthcare burden upon and the healthcare disparities faced by our Black and Latinx communities. It is well established that increased diversity among the healthcare workforce has many benefits, including better health outcomes for underrepresented and marginalized populations, and in reducing health disparities. Yet, the critical shortage of Black physicians, particularly Black men, continues to imperil the health and well-being of our Black brothers and sisters. The statistics are stark. The number of Black males applying and matriculating to medical schools has declined to very low levels. In fact, matriculation numbers of Black males have failed to surpass the numbers from 35 years ago, while the number of positions in medical school have increased during the same timeframe. Given these grim figures, we are especially fortunate to welcome Dr. Tweedy, who has been an exemplar and a role model in shining the light on this important issue for many years. Thank you, Dr. Tweedy, for making the time to speak with us tonight.
Thank you.
Thank you, Dr. Chatterjee, Dean Chatterjee. And so for the introduction, I'd like to introduce you all to Dr. Carl Lawson, who has been the Director of Interprofessional Global Health and also on our Excellence of Inclusion, Diversity and Inclusion team in the learning academic environment, and has really been one of the champions of your book, Dr. Tweedy. So, Dr. Lawson.
Thank you very much, Dr. Olivier. Good evening to everyone and welcome. It is with great pleasure that I will now introduce to you Dr. Damon Tweedy, MD, who is an associate professor of psychiatry at Duke University School of Medicine and a staff psychiatrist within the Durham Veteran Affairs healthcare system. He completed both medical school and his specialty training at Duke. Within the Veteran Affairs system, he directs a team of mental health providers working across 5 primary care clinics. Within the medical school, he leads a behavioral health seminar and teaches medical students advanced aspects of the doctor-patient relationship. He is also the faculty advisor for the Medical Student Psychiatry Interest Group. Dr. Tweedy has written extensively about the intersection of race and medicine, both in academic journals and popular print publications. His 2015 book, Black Man in a White Coat, A Doctor's Reflection on Race and Medicine, made the New York Times bestseller list and was selected by Time magazine as a top nonfiction book that year. I'll also note that his book has inspired and educated many and has informed educational content within our Chicago medical schools and other medical schools as well. Dr. Tweedy, thank you for joining us this evening. We look forward to hearing from you.
All right. Thanks, Dr. Lawson and Dr. Olivier, Dr. Chatterjee, and kind of everyone else involved, and those of you in on the call. Certainly, in pre-COVID, I would be there in person and talking to you all and meeting you folks. And so certainly this is an adjustment, but we will certainly make the best of this the time we have together. Let me start by sharing my screen, and then we'll just jump right in, and we'll hopefully have some good time for question and answer in the back end. So let's get started with this. I should be a pro at this by now. Let's see. That look good there? Everyone see that? Okay, great. Yeah, so I'm going to start. There's really, as again, the title, Reflections on Race and Medicine in the Year of COVID-19 and Nationwide Protests. And we're going to approach this with three main objectives in mind. First is looking at the big picture, the big system, like looking at the education system, the healthcare system, and how they perpetuate disparities. So that's the sort of the big the 30,000 foot view. Then also sort of drilling down to looking at individual provider level and the patient mistrust and what happens at the interface of the doctor-patient relationship and how that can exacerbate these health disparities. So kind of as a psychiatrist, I'm particularly interested in this area, of course. And then thirdly, we're going to look at some of what Dr. Chatterjee mentioned, looking at sort of barriers to underrepresented minority recruitment and retention in the healthcare setting and what some of the clinical implications of that are. So those are sort of the three topics that we'll cover. So it's going to be sort of a wide-ranging, kind of a broad brush overview of a lot of these topics. I'm happy to drill down more in the question and answer phase, and hopefully, if there's not time at the end, if people have individual questions, they can contact me, or the staff here can send me some of the questions. I've done that in previous talks, so hopefully we'll get to that on the back end if we can't cover everything that you guys wish to discuss. So the big picture, of course, 2020 has been a very difficult year for many of us. All of our lives have been changed in some way. Some are certainly worse than others, but two stories, COVID-19 and nationwide protests, have certainly been at the forefront for much of the year. Certainly preceding the election challenges that we're facing now. But these two stories are also part of that story, for sure. And in both cases, the African-American population has been at a central role in kind of both of these larger stories. So COVID-19, as was mentioned earlier, very much so. It's very much highlighting the pre-existing condition, if you will, all the sort of this underlying disparities that have been at work for such a long time. So COVID-19 is certainly, in terms of the Black population, being much more likely to, be diagnosed with COVID and subsequently, be hospitalized and then of course have a much higher death rates. When we're talking about the nationwide protests over police violence, certainly very much African American people are very much front and center of that story as well. I think the important point here is that 2020 we're hearing these because of the confluence of both COVID-19 and the lockdowns, and then all the sort of the social media and how these events have sort of unfolded in terms of George Floyd and everything like that. In some ways, some people are just kind of discovering these issues for the first time. But of course, we those of us, who have sort of been more closer to these issues know that they're longstanding challenges that have led us to this moment. And the next few slides, I'm going to just kind of briefly kind of cover some of the more recent history that led, and then kind of give us to the present time. So this quote from James Baldwin, I think, is really instructive as we kind of look at this topic. This is from a 1962 New York Times essay. It's a very wide-ranging essay on race that he wrote in 1962 in the New York Times. And towards the end of the essay, he talks about how the problem of race will not go away because we in society pretend that it's going to, we can't wish it away. We can pretend it's not there, but it's not going to go away. And it's very much the case. And then after that, he said, not everything that is faced can be changed, but nothing can be changed until it is faced. So, I mean, it's very much the case that in 2020, we were just, for many segments of our population are really kind of just facing this for the first time, at least in real depth. It's a very long overdue conversation. I'm still, apprehensive about where it will all lead, but it's certainly something that you've certainly seen people engage in it who previously had not. And I think the next few slides will really bring us further with this. So when you think about James Baldwin's times, these are some of the images. And so I think one of the challenges when we talk about race in our country is this idea that many people would say is that, why are we harping on something that happened so long ago? This is the remote past. My ancestors, XYZ didn't own slaves, or, people kind of go to that point. Why are we still talking about this now? But the history is not nearly as distant as we would like to believe. These are images from the 1960s. And so, this is my parents' generation. So my parents grew up in the 1940s, 50s, 60s, and they went to schools that were segregated. And my brother went to a school in the early 1970s. So we grew up in a neighborhood that was all Black outside of Washington, D.C. And we were bused to a neighborhood in our district that was all white. So the schools were literally all white, except for our neighborhoods and then one other group of kids from another neighborhood nearby. And so that first day when he was bused there as a fourth grader, the neighborhood, the people that were there, they didn't have signs quite to this degree, but nonetheless, they were surrounded the bus, and basically the message was that we don't want you getting off that bus and coming into our schools because they'll never be the same. It was very much that visceral kind of image, and that's my brother's lifetime. He's in his mid 50s now. I went to that school about 10 years later. I'll have some stories about kind of what my experience was like, because again, I think the past is certainly not as distant as we would wish it to believe. And so this is a sort of an aside. When I see patients, I'm in North Carolina, I'm in the South. And when I see patients in the clinic who are in their 70s, 80s sometimes, and they make some sort of comment, sometimes I see them and I think and I wonder kind of where were they in these images? Because, they were young folks during those images, and what side of history were they on? Again, this is certainly not ancient history in many ways. The people in these roles are still living. And then what about their children and their own grandchildren? So I think about all these things. And again, this is all really important as to what we're dealing with now. Another important take home is that, and this is really important, it's not specifically the study, because most of you are probably familiar with this particular study. The important point here is that medicine and science, which we often think of as being objective and removed from the rest of the world, is very much a product of the world that we live in. I think there's this trap or this illusion for some, like a delusion perhaps, that those of us that have MDs and PhDs and have trained in science are somehow immune to the sort of naked racism that may afflict other parts of society. This image here is, of course, of the Tuskegee syphilis experiment, which occurred during the same period of time, these other images I showed you. From 1932 to 1972, the U.S. government sponsored a research study looking at the natural history of syphilis in Black men in Alabama, without letting the men know they had syphilis or that there was treatment available as early as 1947 in penicillin. So, and you can look back at medical journals from that era, and they'll have studies, and they'll be talking about findings from this particular study. And it's just fascinating to sort of see like the detachment in which they're writing about these subjects as if they're just not. It's a total sort of just total detachment from what the ethical breaches. And so there were some voices in the wind even back then, but it wasn't until the 1970s that enough of a groundswell came aboard that the public got a hold of this and the study was disbanded. But again, it's just a reflection of how the doctors and scientists are also, very much influenced by the larger world in which they live. And I think that's just a really important thing for all of us to sort of take home in terms of messages. So my personal journey with all this started as a medical student in the mid 1990s, so many years later. And if you would have polled the Black medical students in my class, as to which one would be most likely to write a book about race or to give talks about it, I would have been probably one of the last 2 or 3 that would have come to your mind, because I was the student who had been pre-med and had been attracted to medicine by the idea of it being objective. I was a pre-med major. I'd studied biology and chemistry, and to me, it was the appeal to those subjects was that it was concrete, it was objective. You had facts. You could get a certain score in a test, and no one could take that from you. Whereas an English essay, a history essay, getting an internship for business, it all depended on who you knew and your connections, and did the person like you, and those are the ways in which race can certainly be extremely powerful. So medicine held this appeal of being objective and concrete. I initially aspired to be a cardiologist or an orthopedic surgeon, again, thinking about those in very concrete ways. And it wasn't until I got to the first year of med school, though, that I realized pretty quickly that, some of these illusions I had of post-racial medicine were very much fantasies. It became pretty clear during the first year lectures when we learned about every disease. And it seemed like no matter which direction it went, it would always sort of end in the same way. They'd always say that the prevalence was more common among Black people, no matter what the disease was, it seemed like, or that Black people who got the disease did worse. Sort of like what we hear about COVID, right? I mean, so in some ways, COVID is just like the latest story in that longer history and chapter. For me, though, the challenge was there was no context to any of that at the time. This is before there wasn't like a language to describe what was happening. It was just like, well, this is just the way it is. I remember talking to professors, and they just had such apathy or disinterest or uncomfortable. It was probably all those things. And they said, we don't know why it's this way. And it just kind of is what it is. And so that was very unsatisfying in many ways for me to sort of experience that. And it was always framed in this Black versus white kind of dichotomy, which is, again, it's itself problematic, but it was the way in which things were framed. And unfortunately, they still are to many degree as well. But for me, it was also more personal than that. It wasn't just as simple as just these are the data, these are the numbers. It had a personal meaning. This picture on the left is of my maternal grandmother. So she grew up in South Central Virginia. So those of you familiar with the book about Henrietta Lacks, More Life of Henrietta Lacks, most of you probably are. My grandmother grew up in that same time of history in Virginia, about 5 miles away. The town where that book is initially set is about 5 miles from where my grandmother grew up, same time of history. My grandmother was like one of 12 children. Her father died when she was young. She ended up getting to Washington, D.C. She worked as a maid or housekeeper for her adult life. My mom was her oldest child. And as a child growing up, we after church, we'd go visit my grandmother in her apartment in D.C. And this is my first idea about medicine and race and kind of this disconnect, potentially, if you will. So my grandmother had high blood pressure, and my mom would come and talk to her about the different treatments and taking your blood pressure medicine and diet and all this stuff. My grandmother would say things like, I don't know about these doctors. I don't know if I can trust them. I don't know if they're trying to just keep you sick so they can keep your money. And and you know, I wasn't in the room with her when she was seeing the doctor, so I don't know what exactly was happening. But her version of the events is that clearly there was a mistrust. She did not believe what they were saying to a large extent. I think it's safe to say her blood pressure was never adequately addressed or controlled. And by the time I got to college, she had a stroke, you know, several years later. And the second stroke was pretty severe, and she was never the same at that point. And then about less than a year later, she died from heart failure when I was a first-year medical student. So if you think about those diseases, high blood pressure, heart failure, stroke, higher prevalence and worse course among Black people, for sure. So that classroom lesson had a very personal dimension to it. It became more personal for me as I wrote in my book. As a first-year med student, several months after my grandmother died, we learned the ins and outs of measuring blood pressure and vital signs and drawing blood and all that sort of thing. And one day, measuring blood pressure, my classmate found it was a high. The faculty member came in and confirmed that it was elevated. I went to student health a few days later. They did some initial preliminary tests and showed I had some early signs of kidney injury, which is associated, of course, with high blood pressure and notorious disparity you see among African American people. And so there it was. I was like, man, I'm a young man, Black man, and I'm like the statistic that I've been hearing about for the last year and a half, year plus. And what does it all mean? And how do I move forward? And so that's kind of a lot of how this all kind of became. I moved from that post-racial person to someone who was thinking about these issues front and center as I move forward. And of course, one of the challenges is that historically, the medical profession has done a really bad job of talking about race in many ways. And so this is an editorial I wrote in the New York Times a couple months ago, exploring, I mean, it's only a 1,000-word essay. You can only do so much in that short period of words, but there's a lot to hear in terms of how the medical profession has failed people when we're talking about race. The most obvious way is just people ignore it. Just pretend, like as Baldwin says, pretend it's not there and kind of wish it away. But what happens when you do that is that people still fill in the gaps with other things that are problematic. And so, and it's part of that, what they call informal or hidden curriculum. When there's no sort of formal instruction, this is what happens. And so there are two things that I think are pretty, there's more, but these are two obvious things. One is this idea that race as a construct, as a biological construct, this idea that Black and white and Asian are fundamental categories that signify genetic differences across the board. There's a lot of real problems with this. It's used in clinical medicine in many real ways. We're seeing more recently, there's a movement to try and address this issue in terms of the world of kidney function tests, right? So there's this thing called glomerular filtration, where you get a blood test, and then if you're Black, you get it multiplied by a certain number, and then that's your new number. And it's premised on this idea that Black people have more muscle mass than other groups, but really just categorize people either Black or non-Black. And so it's just really, and there's a big movement afoot to try and remove that. And some places are revisiting that in a very real way. We can talk more about that if people are interested. To me, one of the most striking things is like, who determines if someone is Black? Is it a self-reported index, or is it a person looking at you and making that determination? So imagine someone is 90% African ancestry. Okay, they're going to be seen as Black, but someone can have 20% African ancestry, 80% European ancestry. Still, depending on how they look or the hair texture, whatever, they might be perceived as Black. Very different potential genetic ancestry there in what we're talking about. And I've seen cases of people, there was one case not too long, years back, where a young child had symptoms that were pretty consistent with what we would think of as cystic fibrosis. At least that was the risk concern, but the person had a phenotypically Black appearance. And so there was this sense by the treatment team that this person couldn't have cystic fibrosis because that's a disease primarily of European ancestry. And so people were sort of stuck in that sort of wedded mindset. Also seen the converse with sickle cell anemia, where people with Southern European ancestry, sickle cell anemia is associated with Black people, especially in America. And so this idea of being wedded to these ideas of Black versus white can be really troubling and problematic. One thing I found interesting is that going back to the whole kidney disease thing, so one medical center went back and looked like who was determining who was Black and who wasn't. And in half the cases, it was the people at the front desk, just basing on what people look like. So it wasn't even the patient report. It was nothing. It was just like, this is what I think this person is based on how they look. You can sort of see how flawed that is, right? And so I think medicine for a long time has held on to that kind of a approach. And that's really very problematic. We really have to address that in a very thoughtful way. The other piece, of course, is the idea of sort of, there's a lot of terms for this, blaming the victim, if you will, or this idea of focusing on Black people as if they are intentionally making bad decisions in every area of their life with the intent of sort of hurting themselves. And you see this come up a lot in people in this informal way, in terms of some of the snide comments you might hear. The picture of the gentleman below is actually a physician and a state representative of a Midwestern state. And it was interesting because there was a public debate over COVID, right? It's just happened several months ago now. And they were talking about the issues of COVID and the higher rates among the Black population and why might that be and what could we do about it, right? And so this guy is a doctor, comes out there in this conversation in a public forum and says, well, maybe Black people, their hand hygiene isn't as good. And that's why they're getting COVID at higher rates. And it's just the idea that you could sort of have that kind of flippant biased perception. And so my first thought wasn't about the content of that. My first thought was like, man, what does this mean for this guy's patients, all the Black patients he might have seen over the years? If he can just sort of have that kind of casual, negativity assumption in such a way. Because just for those of you in the audience who aren't Black and maybe curious about this, so I'm a psychiatrist, right? And so in my field, it's been long known that the white population has a much higher suicide rate. And so you can speculate as to why that might be. I mean, there's all sorts of factors, right? But let's just say in this, for the sake of some public hearing, I just go out there and say, oh, well, it's because white people, they have bad character or something like that. Well, I would say if you're a white person and you heard me say that, you might wonder about how I'm treating white patients, right? So I think it's just, these are very dangerous assumptions that people make. And again, the idea of him being trained in science did not immunize him against those sorts of biased perceptions. So these are just things I think they should all kind of consider. Another piece I think is really important, doesn't get talked about probably enough, is the medical chart itself. So every doctor is writing a chart, they're writing a story about a patient. A person comes in with a presentation of they tell you their story, their symptoms, whatever they're bringing to the table. And then you are translating that into a document, a living written document that then the next person sees and the next person sees. And I can't tell you how many times you see a chart and you start to form all these sorts of things based on what you've seen, based on what someone else has labeled or described someone. This study here was a couple years back. It was looking at the sickle cell anemia population in Baltimore, and they were looking at real charts written in the emergency department at Johns Hopkins, the esteemed medical center in Baltimore. And some of the descriptions were just mind blowing. The ways in which they were describing these patients, they were very racialized, very stereotyped kind of descriptions. And what the upshot of this was that people described in that way were much less likely to receive the appropriate pain medication treatment when they were in crisis. And so it was the idea that these words, the way people were described, really mattered. So they've been described one way, then they come in the next time the person sees how they've been described, and they're already biased against giving them treatment because they say, oh, this guy is. There was one example in there, and there's many, but I haven't looked at it in a while. There was a case of a guy who was dehydrated. Dehydration can cause make you have a propensity to having a sickle cell crisis. And the way they described it, rather than just saying he was dehydrated, they went to this long explanation as to how he was hanging out at a street corner with homeboys and not doing anything. It was just like, what is that? Why is that in a medical chart? What use does that serve other than to just express your own sort of animus or bias towards that person? Like, what clinical use is that, right? And so I talk to doctors a lot, and I was like, well, when you're writing in a chart, what are you conveying? Because everything, it means something. What words you put have a meaning to it. And like, what are you trying to convey when you describe someone? Are you just angry? Are you frustrated about whatever may be the case? And so these are things that are really important. So I think all of us can take that message home. It's an extremely important one. This kind of speaking of this issue of bias in the medical field. So I'm a psychiatrist. I'm not going to pretend here and just cast, throw bricks or throw stones at everyone else, especially because my specialty is very guilty of this stuff too as well. So this is an advertisement circa mid 1970s about schizophrenia. So I'll tell you this. So nowadays schizophrenia is there's a lot of research showing how it's much more likely to be diagnosed among Black people, Black men in particular. But what's that all about? At one time, schizophrenia was actually thought of as a disease of well-to-do white people. And this is funny how, psychiatry is really problematic because initially they blame moms. They blame moms for causing schizophrenia in their children. It was typically blaming well-to-do white moms. Somewhere towards in the mid 60s, in the context of the civil rights movement and the Black Power movement, all these sorts of things, schizophrenia became something else. It became this idea of agitation, paranoia, and this idea, it became a Black face began to be put on it. You started to see this much higher rates of schizophrenia being diagnosed among Black men in particular. So this is a medical journal advertisement circa the mid 1970s. Haldol is those of you probably who've worked in the emergency room setting will know that's a potent antipsychotic drug often used to sedate people chemically when they're agitated. It's an old antipsychotic. It's still used a lot in the kind of emergency room settings. So this is back when it was still a brand name drug. And what they have here is this is a medical journal that's going to be psychiatrists with 98% white, probably in the 1970s. This is a very white audience, and they have a Black man here with the fist and all that, and they're saying cooperation begins with Haldol. And so it's this whole idea of control and this image of blackness as being violent and aggressive, assaultive and belligerent, right? And so it's a powerful narrative. And I think, and there's no doubt they've traced how the rates of schizophrenia have certainly increased over time. And so I can't tell you how many times clinically I've seen people in practice have that diagnosis in their chart. I talk to them, look back at the record and think to myself, how did this happen? How did you get that diagnosis? And you just wonder. And of course, these kind of images kind of help you think about how that so many things came to be. And it's not to say that people don't have schizophrenia, that some Black people don't have schizophrenia. Certainly they do, but there's certainly a subset of people you will see who actually do not. And it's certainly a function of this history. So it's just a real lesson for us. So anyway, moving forward, the things that we see in the real world, of course, there are all these social determinants of health. I'm going to kind of go a little more quickly through these slides. These are certainly all important aspects. And this is a vocabulary we didn't have when I was in training as to, education and money and health insurance, all these things impact health outcomes. The next few slides will show you some images of places that I was at that sort of illustrate this. There was a town I write about in the book. We don't have time to go into it now, but basically, the whole gist was that we got to this clinic. Back then it was surrounded by cotton fields, a town divided black and white, very much the old South kind of imagery. And it was just so striking to see how different the care could be delivered depending on the setting you were in versus being a Duke versus being, an hour away and sort of seeing whether, people can have these jobs that seem like people can do things the right way and the system still kind of lets you down, no health insurance. Of course, we'll talk about this maybe in the Q&A, like, where are we going next? What's the next step if Obamacare or Affordable Care Act gets gutted? Where do we go? We can talk more about some of those things in the back end. You see these disparities play out and obviously in all sorts of public health settings, FQHCs. I worked at a state hospital. A quick story here just illustrates, kind of a depressing story, but a quick illustration of how these social determinants can play out pretty profoundly. So one night I was in the ER. There were two women. I was in the psych ER at this point. Two women came in with pretty similar psychiatric challenges. In our world, this is pretty common. People have they don't cope well with sort of change and conflict, and relationship goes bad, and they take some overdose of pills. And this is not an uncommon, unfortunately, scenario in psych. The upshot is that two women needed similar kinds of treatment. On paper, they look similar, but in practice, everything was different. The first woman was white. She had health insurance. So what that meant was a nurse from the unit could come down and take her to the unit where she'd have her own room and be treated like the best way you could under circumstances. She'd have her own room, daily therapy, group therapy as well. The other person did not have insurance, was Black. And what that meant was that her only destination, because this is the reality in our system at the time, was that the only way she could go was a state hospital. And so I showed you the slide. The state hospital is pretty gritty, particularly someone who's never been in treatment before, chronically ill people who are potentially violent, very different setting. You share rooms, you share bathrooms, it's a very different setting. Not a great place for someone who's denied to treatment. But the worst part was how that woman got to the state hospital. And so what happened is that she had to be, police had to come, because that's the process, that's the system, if you will. And so police had to come take her and put her in a handcuffs and in a police car, and that's how she got to her destination. So you have someone who comes for voluntary treatment, seeking help, and this is what happens to her. And it's a striking illustration. When people talk about how there's a term called racism without racist, or this idea of systemic bias, systemic racism, I think this is what they were talking about. This idea of that there's no individual actor involved, that literally the system put these people across two different destinies. And this is a really powerful illustration when people say, what do you mean when you say that? This is an example of what it means. It was a very powerful thing that I've sort of kind of always stayed with me over the years. I mean, there's been interim changes, but it was such a powerful thing to see as a trainee when I was going through the time. So when people ask me what's changed the most since I started med school, this is really one of the biggest changes, are the students themselves in terms of their orientation, their activism. Been a lot of changes since the last 7 and 8 years or so in terms of the kinds of students. When in my generation, we were much more sort of accommodating, just trying to get through. We'll get through, and then maybe the next generation will have it better for the next group. And so we found ourselves questioning that, and now we're seeing this in the moment. Like, did we do things the right way? There are these real challenges that we face as generational conflict. What I've seen as far as the new students in terms of their activism, they're pushing for change, and some of it I think is great. One of the challenges they're facing is that they're trying to push for new curriculum and things of that sort, and med schools are trying to adopt that. But what's happening a lot of times is that the schools themselves work at a very different pace. Maybe the faculty aren't as attuned to these issues. Maybe they don't have the experience to teach it because they don't really know much about it. Some may not even be sympathetic to it. So this conflict is happening in different ways. But I think for the long run, for the greater good, this is going to be good development in the long run, that the students are being active in questioning and challenging the status quo. So I think that's the biggest change that I'm most hopeful about as we move forward. The last segment, I'm going to kind of turn to the personal side about the being a Black doctor piece. So this is an image of me as a young fourth grader, and then that's me as a fourth-year medical student. Get it mixed up. Fourth-year medical student, right when I graduated from medical school. Too many fours there. So the issue is this. So what do you see when you see a 6'6" Black man who's not in a suit, who's not in a white coat? What do they look at? Like, what are they seeing when they see that person? And I think so much that drives what we continue to encounter and face, and the challenges and struggles that we see that could play out in so many ways. So for me, it happens in all different ways. So even as a first-year med student, one day I was driving home from driving back to Maryland from North Carolina, got pulled over at the North Carolina-Virginia border by a police officer for speeding over 4 miles over the speed limit. The very first thing that the police officer said was, boy, you better not have a gun or drugs on you. Do you have those things on your possession? Very first thing, like just right off the bat, do you have drugs, or, gun or drugs? And so it's pretty clear. So it's pretty clear where he was going, right? What he saw when he saw me. And I remember just the idea of the fear kind of comes over you that moment, but also this idea that I needed to find my medical school ID badge to sort of validate myself, and just all the sort of problems that sort of just all what that story tells about our society and what people see when they see you. There's other things, in the book I talk about, the professor who asked me to fix the lights in the classroom, or the patient who says he doesn't want an N-word doctor. I mean, these things happen in all sorts of ways. The upshot of it is that people, you can think of yourself as wanting to blend in, but and be like everyone else. But there's times when the external world will tell you you're not, and you have to kind of figure out how to navigate that. That's sort of the upshot of that. And there's all sorts of ways we can talk about, moving forward. There's many good things that come with it as well. There's many patients who, you see a Duke and they say, this is the first time I've seen a Black doctor in 30 years of coming here, and it feels so good, and so good for people like us to see you in this role. So it's a lot of things. It's not just one thing when people see you, there's a difference, and you have to you can't just pretend it's not there, and you have to sort of embrace it and figure out a way to make that work for you and for the people that you're trying to care for. But it's a complex web of things. The story about me as a little kid, I don't want to go into it, I don't probably enough time, but the gist of it was that as a student there, I was really good at math, and the teachers, it's all white teachers, they were sort of taken to me by the fact that I was doing well. And at first I thought that was a really good thing, and it was on some level, but then it became something more when I realized how they felt about all the other students, because one of the teachers openly talked to me, I was staying there with the two other teachers, and the one who was my teacher told the other teacher how great she thought I was, but then she said he's not like the rest of those savages that come here. And at the time, it's bad, but you don't really fully process, like, what did that mean for all those kids at that school if the teacher could just openly have that attitude about those kids and their potential, right? It's just so problematic and flawed at the upswing. The other thing that me personally has experienced as a really tall Black man, of course, I assume you play basketball. I did play basketball. I love basketball, but even that can be limiting in its own way, because I remember in high school, I walk into the classroom and the teacher tells me that, you should just focus on getting the minimum. My goal should be to get the minimum score in the entrance exams so I can maintain my eligibility for basketball and to get into college. And I thought, man, that's just such a crazy thing to say without knowing anybody. See, people are already being limited and boxed in before they even get started. I think those things are really important when we talk about narratives and about how people see themselves and how the world sees you. I think we have to continue to fight those narratives at every step because they're really powerful. Another important piece is that this hasn't gone away. I talk to young medical students all the time. They talk about the challenges they faced. Here's a lesson for the faculty. So particularly if they're white faculty on the audience, this is really important, because I think what I see a lot is that students experience these challenges and faculty don't know what to do or how to respond in the moment. This happens a lot. So I had a student not too long ago who was from a Hispanic or Latinx background. Another student was Asian background, and they went to a patient room. The patient was white, and the patient just was like throwing out slurs at both of them, just like candy. And they were taken aback. They went out to the faculty person who was white, and they said they said what happened, and he was like, "Oh, don't worry about it. I'll see the patient," and just that was it. And they never discussed it. They never brought it up, and I just think and never brought up with the patient. I thought that was really problematic because the students had a lot of hurt from that. He never asked them how they felt about it, what they would like to have done or seen him do. He never addressed it with the patient, and there's so many missed opportunities, even though he probably thought he was doing the right thing by kind of avoiding it and trying to work around it. This happened. I gave a talk at a place in Northeast, in a very blue state in Northeast, not too long ago, where a patient was in the ICU, and the patient's husband said he didn't want any people of color touching his wife. Now, in this particular case, the doctors were all white, but some of the nursing staff was black. And the staff sort of was silent and didn't do anything. And they just sort of were taken aback, and they just sort of passively kind of accepted it. Again, just I think very problematic. They only went back some days later after I talked to people, and they went back some days later, and they told the patient, that we feel like this is really problematic. You shouldn't, say or do this sort of thing. And the patient the patient's husband was subsequently apologetic. Like, oh, I'm really sorry. I mean, whether he was sorry or not, the message was clear that this was not something that you should be doing and can't do. And we need to support. And the most importantly, the staff felt so supported because whether you pretend it's not there, the problem is there, and the staff were feeling hurt, and it was just totally kind of ignored. And this doesn't mean that we should ignore patients. And of course, in some cases, if it's urgent versus life-threatening versus like a clinic setting, how you respond might be different. But I think the bigger picture is we have to be mindful of this, right? And not just pretending to ignore it. These things are still very real. Another challenge about being a Black doctor, of course, is this idea of this idea of a double consciousness, this narrative. Is W.B. Du Bois, this idea of always trying to navigate two worlds. Very much a very real experience that I had and many other people in my field have experienced. But yet there's been really good stuff. So this is another editorial I wrote in the New York Times many years earlier, before my book came out, actually, looking at the role of Black doctors in the care of Black patients. And I got to tell you, this is really interesting for me because I can't tell how many people have told me that they feel like I've literally saved their lives in so many ways. And it transcends specialties. It's really, and it's humbling because, you feel you want to help people, but people tell me that they stopped their diabetes medicine, or they wouldn't go back to their ophthalmologist. And I got one guy to go back to his ophthalmologist, and they were able to finally address his glaucoma. There's so many different things that people have had where they've sort of given up on healthcare in different ways. Whatever it may be, they won't take this particular antidepressant, whatever it may be the case, and then seeing me was able to help them get back on track. But it's also kind of like troubling because there's a sense of you that wonders, like, we don't want segregated medicine. We don't want to go back to that world. We had that world many years in the past, but it's also troubling to think that I could have that much influence on someone, and that if I hadn't perhaps been in that position, who knows what might have happened for that person. It's sort of troubling to think that, wow, the system could it be that broken that people could be that could give up on it that much and be at harm in that way. It's sort of a troubling thing to think about. But at the same time, it also shows how important it can be to have Black doctors in this world. I see it more as an issue of choice, because there's some patients for whom this is really important. So, like, for instance, in my field of psychiatry, there's some women I see who have had significant trauma at the hands of men, whether physical or other sort of trauma by husbands or ex-boyfriends or assailants of other sorts, and they really need to see a woman provider. And I think, who am I to say that they don't need that? And I think in some cases they really do. And it's helpful that we have those options for people who need that. And so I think that there's no doubt there are some Black people, whether it's in psychiatry or primary care or whatever other specialties, who would really, really, really need a person of their own race. And to not have that choice is where we get handicapped, because the reality is that the numbers are really low. When I was a trainee in psychiatry in my clinic, I was the only Black trainee. Our clinic served 45% Black population. Pretty quickly, I had almost twice as many patients as my other colleagues. And you can see how that fosters burnout. I'm one person, and here I am trying to shoulder all the load of everybody, right? So this again shows how we really need to address these issues in very fundamental ways. And I think that burnout I'm going to go to another slide in a minute, which I think will illustrate that. So here are the numbers. Again, 13% of U.S. population is Black, about 5% of Blacks and doctors. That 13% is much higher in places like Chicago, places like Durham, where I work, North Carolina, Atlanta, DC, a lot of places where there's a lot of big, well-known hospitals. Numbers are much higher, and you see real striking disparities. That burnout, I think, is part of what we see here. There's other factors at work too, but you see there's kind of this attrition, right? 7% of current medical students are Black, which is about half the general population proportion. But then you see as you get to the faculty level, assistant professor, associate professor, full professor, numbers kind of continue to dwindle. I think part of that is the burnout from what I just described before, this demands of trying to meet the needs of all the Black population. There's also this idea of being put on all these committees and having to do all these different things, but not be valued in the same currency of academic medicine as other things. So, like, when it comes time for promotions and whatnot, all that work you did on this particular committee or on this project, it's not valued the same way that scientific publications are. So it's like you're still being measured on the same metrics, but you're also being asked to do all these extra things without the support, financial support, or the academic sort of support. And so I think these are things that systems need to do to rethink. If we're really going to make these things serious and important, we have to rethink how we're even approaching that, because otherwise we're going to continue to have these problems persist. So I think it's for those of you in the institutional level, these things I think you really need to think about moving forward. So speaking of moving forward, I think for me, this is the last slide. The important piece here really is just like, how do we, for me personally, a real important part of my thing is changing the narrative of what it means to be a Black person in America, in medicine. These are social media handles that I've come across, people I've come across. The point on the left is based out of Ohio State. Guy's a cardiologist there in the suit, and the people on the right are from Texas, Dallas, Texas. I think is a pulmonologist. He was formerly at Duke. And so you can see they're really trying to change that narrative of being a Black man. Because again, this has been I just can't tell how powerful that it really is. And I'll bring it back to at the very end. So when we think about what's at stake here, this quote from Dr. King is really, I think, really instructive, because this is not like, people sometimes want to make this about just like a philosophy or it is about politics, but really more about like an argument to be won. But really, the stakes are much greater than that. I mean, this is not just like a debate class, conversation. This is life and death stuff. As Dr. King's quote illustrates, the inequality we see in health is really the worst, because people are dying. I mean, we're talking about profound differences in life expectancy. We're talking about, the higher rates of COVID and the death rates of COVID and everything else, maternal mortality, infant mortality. These things are all very real and powerful, and we see it in all different shapes and forms. Another thing, quote from quote, I think is a quote from King, which I like, is this, because it understands that we have these huge challenges, system challenges that are centuries in the making. Yet we can't lose sight of our own individual power and agency to affect change. I think sometimes it's easy to do that. So for me personally, I think back to me being an 8th grade student in a low performing middle school. It was 98% Black. Many of the kids were not on the trajectory to go to college. I'd never met a Black physician at that point in my life. If you would have told me as an 8th grader I could have been a doctor, or I could have written a book, those would have been like, come on, like, who are you joking with? I probably hadn't hardly even read a real book from cover to cover at that point in my life. I was that kid who would always try and cut corners and read the intro of a book and then like get the cliff notes or something like that and try and figure out what it all meant. I was that sort of a kid, because the stories didn't seem like they had any relevance to my own personal life in any way. And so, but I had a teacher as an 8th grader. She was a math teacher. She was white, and she encouraged me to take an entrance exam for a magnet program. And I was the student who said no, because I'm going to be the only Black kid there. I'd already told myself in my own narrative that maybe I wouldn't be as good as the white or Asian students. I'd already had that sort of ingrained in my head from society that I couldn't keep up, sort of thing. But she was a person who pursued and persevered, because a lot of times in society, people will say, well, we'll give up on you. We'll try to help you, but you couldn't help yourself. So too bad. She persisted. I got this exam, took the exam, got into school, did well in the exam. And it was amazing, because that really helped reshape how I thought about my life and where I could fit in the world, and begin to have ambitions beyond sort of my own sort of, what I could see beyond what my own little environment was. I'm a 1st generation college student, so much less 1st generation professional school. And so this was really eye-opening for me. And so I think there's a tremendous power we have as doctors as well. When we think about the patients we see, sometimes there's a tendency to sort of like kind of be skeptical, or to like, I feel it myself sometimes. This person's never going to stop drinking, or they're never going to do this, or never going to do that. She's never going to leave her husband, or whatever may be the case. You may think these things, and then patients will surprise you once you follow them for over a period of time, and you're like, wow. And then they'll tell you that, you were helpful in them coming around, even though it seemed as if you weren't helpful when you felt like you didn't feel like you were helpful, but it turns out you were. And so I encourage you guys to never lose sight of that broader role that you could have in the big picture. So that's just a really important take-home message. The final thing I want to say before we, in case it doesn't come in a question answer. So this is my slides here for contact information. But I want to say is like, I think when we see providers and we see patients come into our space, we should think of them this way. We should think of that person coming in with a bag. That bag contains all their history, their personal history, their family history, their family's relationship to medicine, the cultural history that they've sort of grown up with, whether it's Tuskegee or whether it's just my own grandmother saying things she said about being a doctor, or the bad experience she might have had. We bring all that into the room when we see a doctor. So I see doctors sometimes get defensive and angry because they feel like the patient's upset at them. But like, it's not about you. You have to understand, what is that person's story? What have they brought to the table? And then you also understand, what is your story? What have you as a doctor? What are you bringing? What is your bag? What's in your bag that you're bringing into that room with the patient? I think the more we can understand those things, the more we can have humility and less judgment, the more we can really do right by the people that we see. So I think that's like a really important take home as we move forward in this larger sort of puzzle, because there's enormous big scale things we got to address, and we can talk about those. But I think we also never lose sight of the individual small scale things that we can continue to do in the midst of all that as well. So I'll stop sharing and take questions.
Thank you so much. That was so rich and so powerful. I want to thank you once again. I want to go right into the questions and answers and have our medical student introduce themselves to you and ask the questions.
Hi, Dr. Tweedy. Thank you for joining us this evening. I really enjoyed your talk, and I thank you for your wealth of knowledge. The first question that I would like to ask you is, do you foresee the Black Lives Matter movement as an essential and impactful tool in bringing about awareness and improvement in the African-American healthcare?
Do I see Black Lives Matter? So yeah, so there's kind of like certainly certainly. So I think some of that is animated the students. Some of the students in the movement, the younger students are sort of pushing forward. I think a lot of that is coming from that sense as well. The thing about I think the thing with labels is that, because, these things get sort of politicized, and someone will see that label and they'll think this, they'll think that. I think the more and this is not me saying my own personal opinion, but I know that some people, I've seen it happen, actually. I've seen it happen where a student will have like a Black Lives Matters, sticker or pin or something, a lapel, and then you see a faculty person get worked up about that sort of thing. I've seen it happen, and I mean, I could go on the whole story about that. The point is, back to your main question, is it important in terms of how we move forward with medicine? Are they providing energy and animation to making change? I think to the extent that is happening, yes, that's a very important piece. But yeah, I mean, we're in a bad place. I mean, I saw one time a patient had on this is crazy. This person had like a I can't breathe shirt. Not the patient, but the patient's family member. And then the doctor got so upset that they asked the person to leave, and it was just like, wow, what are we doing? So I'm always cautious when we talk about specific like movements, but in terms of the labels. But I think it's really important the work in terms of and the inspiration in terms of where that will lead. So I think that's the message that I want to sort of convey.
Thank you.
Yeah.
Hello, Dr. Tweedy.
Yes, sir.
My name is CJ Roberts. I'm also M3, and I just wanted to read some of the questions that we had in the chat. I'm just going to read the first one.
Okay.
Okay, so the first question submitted was, the difference between the different measures for GFR for Blacks is concerning when put in the context of knowing Blacks die more often by cardiovascular problems and heart disease. I have a family member with a white mother and Black father, but looks white. And what test does he get? It's too subjective. Do you think this plays a role in Black mortality?
Yeah, well, I think it's something that, I mean, so I'm not a nephrologist, I'm going to put that out there, but this is something that, yeah, I mean, these are the limitations of it, right? So like what someone looks like, so if someone looks white, then we don't get the correction. And so I think the challenge with the whole idea of the correction is that it's supposed to, the concern is that maybe it makes Black people who have kidney disease seem like they're doing better than they actually are. And so maybe they're not getting as aggressive treatment as early on. That's the upshot about that whole thing. But yeah, the idea that how you look, I mean, this is why you really have to have a doctor who's kind of understands some of this stuff and really can get beyond just the surface layer of making this determination based on a subjective sense of skin color. I think the genetic ancestry, of course, is a much richer, better approach that medicine has to get to that point. We're certainly not there. We're still using these sort of crude labels of black and white, which are really limiting when we think about them from any sense of a biological standpoint. So yes, I think yes. The short answer is yes. That's important. They need to certainly talk it out with their doctor and kind of come in with this information and sort of see what it means for them as an individual person. Yes, that's a really thoughtful question. And it underscores the limitations of the whole thing, the enterprise.
All right, so Dr. Tweedy, we have another question in the chat. And that question is, as you may already know, there is a growing field of personalized medicine where we are using complex machine learning algorithms to help us identify disease heterogeneity. Oftentimes, these algorithms use race in addition to a number of clinical, phenotypic, and genotypic and proteomic factors. and can develop meaningful prognostic information, even medical treatment. I'm worried what eliminating race in research may hinder this understanding of disease heterogeneity. Do you suggest we use information about race or ethnicity in this manner? If not, can you explain how eliminating race and ethnicity in these algorithms is not simply accepting a problematic post-racial medicine?
Yeah, no. So look, so my point is not to sort of say what we need to do and to make rash changes. My thought is that we need to be thoughtful about what we do, how we got to the point where we are. Like, what were the studies that sort of, because one of the studies that sort of looked at muscle mass, and how we got to this GFR thing was it was saying that Black people had more muscle mass. It was based on a really small study, but yet all this sort of clinical stuff is happening as a result. So I think it's really more about how do we get to where we are and being thoughtful. I'm not saying we need to make any changes rashly, because I don't think that's necessarily in the best service of people either. So my point is that we need to be thoughtful about what we're doing, interrogate how do we get to this point, because a lot of times in medicine we just blindly accepted things for a long time. I do think, to the degree that we can have more personalized medicine and understanding things, yes, that's better. But so that person maybe so I want to convey the message. I'm saying we need to just tear everything down right now. My thing is we need to understand how we got here. What are we doing that may really be problematic? 'Cause I think some stuff, it really is problematic, and you'll see it is. But understanding why, then what can we do to make the best solution? So I'm not here to say I have all the answers, because I think it's very complicated. But right now we've been doing it very binary and very simplistic, and that's also problematic. So we got to find a better way is what I'm saying. And we see this in psychiatry. I don't have time to go into all that, but they have some of the same issues with psychiatry. Certain medications are supposed to be worse and better than Black people and all that. But again, a lot of that's complicated by a lot of other factors. So we have to sort of explore that in a more detailed, thoughtful way.
Thank you.
Yeah. So while there are other questions, because what I was going to say, I've also seen this one time, like with the blood pressure medicine. I was like, there's this idea that certain blood pressure medicines for Black people are not. And I saw one case where a patient who was Black was on a medicine that was not thought to be a medicine that was, quote, the best for a Black person. This doctor went to a new doctor. They convinced him to switch to a medicine that was, but then he subsequently had a bunch of side effects from that one. He would have been better off just staying on what he was already on. But it was like this idea that we had to do something because it was racialized. Again, I'm not saying we need to eliminate race, but I think we need to be thoughtful about what we're doing and why we're doing it, and not just box people in so willy-nilly like that. So
yeah,
go ahead.
So I was reading the other ones in the Q&A. I'm trying to make sure I go by time as well as when the question was asked, as well as trying to make sure there's no repeats. So I was going to read this question. Dr. Tweedy, thank you for taking time to speak with us. I had the pleasure of reading your book as an African-American studies minor. Make a connection between your presentation today and your book. You wrote about having a special obligation due to understanding the language of medicine while serving patients with limited formal education. How do you recommend that Black students, aspiring physicians, fulfill that obligation to better assist patients in times like these?
What do you mean by times like these? You mean like currently now specifically, or what do you mean by that? What do you think
I think they mean in times such as COVID, but I'm not sure. Let me see if they can clarify.
Well, no, yeah, I mean, yes, so like, what are your obligations? I mean, I think there's, certainly this is every person sort of has to make their own choices as to what they're going to do, right? In terms of this, for me personally, you can reach a point in medicine as a Black person that maybe you feel like, I'm just going to put it out there. There was a point where you start to feel like maybe you've kind of made it, if you will, and that, some of these, you can kind of feel like you're, some of the problem. So part of why I wrote this book and have been engaged in this is sort of trying to maintain that connection, maintain that, because I feel like a lot of people's stories, I'm in a position to be able to represent a lot of folks and be able to share their stories and give voice to some of the things that maybe they aren't, to give the voice to the voiceless in some ways. So I think it's been really important for me, and that's a lot of what I valued in the work that I do. So certainly in this time of COVID, it's really important to have that conversation. One of the issues, like I think like we're gonna have a COVID vaccine at some point, right? And what are people gonna do with that? And so, there's a lot of mistrust that you see in certain populations where, some polls have said Black people are gonna be less likely to take the COVID vaccination. Some of the early studies had a hard time recruiting Black people to be in the studies. So where's our role as Black doctors in trying to bridge some of that trust? I think we got to be honest about what's happened. You got to have some like truth and reconciliation kind of thing. Like what's happened to lead us to this point. But I think we ought to be advocates to the extent that there is, good knowledge and scientific knowledge. We need to be advocates for our people. A lot of times I've been sort of this translator, if you will. This kind of maybe it speaks to what this person's asking. I felt like I've been a translator where I've been in a role where a Black person may be mistrustful of conventional medicine in some ways. And I've sort of had to kind of step in and be like a translator to help them sort of reassure them, if you will, that in certain cases, this is the appropriate treatment, and sort of be an advocate for that person.
We're going to have our last question, Laureen.
Okay.
Oh gosh, I'm sorry. So what I can do for those if there are other questions that I don't get to, if you want to send them to me, I'm happy to sort of, with the time I have to send responses back as best I can. Like if you could put whatever's in the chat or whatever and just email it to me, I'll do my best to get back to those. I'm sorry I give some long-winded answers. This is why I'm not a politician. So I'm really sorry about that.
Well, maybe I'll ask you a question and we'll send the other ones to you. Did you get that talk? And would you give the talk to your children?
Oh, the talk, right?
The talk.
Of course. Oh gosh, yes. My dad was so much into that. He was so worried all throughout. Man, he's like, you got. It kind of connects to this. There's another talk you get as a Black person is like, you got to be twice as good. And those talks are connected. I mean, they're connected. This idea that you have to, you can be with your friends and they can do all these things and they're not going to get in trouble, but you as a Black person, they're going to single you out. So I've had that talk. I had that encounter with the police, that was there. I'm glad I had that talk when I had that encounter. Because I was scared to death when I had that. And I was glad I'd had that talk. I have two sons. I have a 12-year-old, I have a 10-year-old. So I'm really tall, right? And they're also pretty big kids already. It hurts to think about that, right? That you have to have this. And so it does hurt in a way because they had an incident once kind of outside the neighborhood where this person basically, they were out walking a dog on their bicycles, and this person said, they never know to get out the way. And so my younger son runs back home, he's afraid, doesn't know what it means, and he's afraid. And so that was the beginning of the talk already. And I was thinking, man, I was hoping he could get a little older before we had to go there, but we had to go there earlier. Because the thing about the talk is you don't want to, I'm sorry if I'm talking too much, but you don't want to feel like you're like, you want them to just feel like everything is open to them and the world is an oyster. And it feels like if you give them that talk, you're kind of saying it's not really true. And that's a hard thing to sort of do as a parent to your kid. My parents had that as well. And so, yes, I think the talk's going to be real for a foreseeable future. Again, it goes back to what people see when they see you. I mean, if I can't tell you how many times I've been in casual clothing and just people have thought the worst. I was in a Dunkin' Donuts like 20 years ago, and this guy thought he said I thought you were going to rob the place. I got so angry at him. I said, well, what made you think that about me? Like, what did you see that made you? I actually just said it right to his face. And then he got really apologetic. I was like, no, I'm not racist. I'm really sorry, blah, 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 blah. But it just shows you that it's a very real, I don't want to end on this downer, but that talk's important. Yeah, it's a very real thing. It's not going to go away. We got a lot of work to do. We got to vote. We got there's so many different levels, but you got engaged with all these issues. There's the big picture. We got to vote, not just nationally, but locally. We got to engage with our communities. I mean, there's so much to do. And that's just sort of, I never thought I'd be in this trajectory when I started med school, but this is where I'm at, and I'm glad that I'm here. And so final thing I'll say is this, rather than take it as a burden or a curse or a tax, I look at it as an opportunity. It's actually a gift. I've been in a position now where I can sort of help people as they move forward in their own lives. And I've also really reached out to, there's a lot of white people out there I've reached out to in ways. This is really interesting. Most interesting about it is there's white people out there who are sort of in the fence, don't really know where to believe, know which way to go. I can't tell how many people I feel like I really made some real positive impacts. I mean, there's some white people out there who said things like, this one guy told me when he saw my book, he was upset. When he saw the title of the book, he was cringing. What does that say about where he's coming from? But then he said he read the book and he learned things about, race relations that he had never thought about in his life. And then he started doing all these things. He kept communicating with me. So it really impacted him in a really real way. I've had doctors say the same thing, like doctors who've said they never even thought about race in medicine at all. They never thought about it. They thought they were post-racist or whatever you want to call it. They never even understood that what they were doing may have been hurtful to people. And so it's really important. So I think it's a gift. So I think all of you out there who want to do this, you can look at it as a burden, but I look at it as a gift and opportunity to really push things forward. it's a blessing to be in this position that you guys are in. The more you can think of it that way, the more you can really do good and not get dragged down by everything that we're fighting against.
Well, I want to thank our attendees. I want to thank you, Dr. Tweedy, for just an amazing, powerful talk. I want to thank our medical students for doing the chats, Christina for putting this together, and I will give the final word to our dean.
Thank you very much, Dr. Olivier. Dr. Tweedy, that was an amazing, amazing talk. And thank you again very, very much for answering the questions from our audience and for your graciousness in agreeing to answer the ones that we weren't able to get to.
Yes.
My thanks as well to everyone who was here tonight. And special kudos to our Office of Excellence in Diversity and Inclusion for continuing with this series of discussions around race in medicine and the impact that racism has on medical education, on health disparities. And I would just add to what Dr. Tweedy said, and that is that it is each of our obligations to continue this battle. And the only thing that will bring about change is if each of us is committed to making that change happen. So on that note, thank you. Have a wonderful evening, and we'll see you at the next seminar that we have. Take care.
It was a pleasure. Thank you so much.
Again, Dr. Tweedy.
Yeah. Good luck, guys.